Good morning, Ashutosh sir. Dr. Abhijit here.
Good morning, sir. Good morning. How are you?
सर ऑल गुड. आई एम इन यूएस. अभी रात के 1:30 बजे है, तो मैं थोड़ी देर जरूर अटेंड करूंगा, फिर आई विल विथड्रॉ माई सेल्फ बिकॉज लेट अवर हो गया है. आई हैव जस्ट शेयर्ड अ
Oh,
वेरी गुड रीसेंट आर्टिकल इन द ग्रुप. अभी मैंने भेजा है.
Okay,
आप फिन एरन के बारे में ही
okay,
है. इट्स अ
okay, sir.
2024
Okay, sir.
पब्लिकेशन.
Okay, sir. Okay, sir. We'll see that.
जी.
Okay, sir. Dr. Nikhil Agrawal has also joined. Dr. Susma, Dr. Abhijit, Dr. Jagnani, Dr. I request all of you to please remind your friends so that they can join and they can get benefited from the scientific meeting. So, Nupur, can we start? So,
yes, we can
Dr.
start.
Abhijit, Dr. Abhijit,
I think something else. Yeah. So, good morning, everyone. We have a good number of, I think, participant in the meeting now, and we can start with our meeting, September newsletter for CardepCon, and it has very exciting topics to be covered. So, I will invite Dr. Ashutosh to start with our meeting today. Over to you, Dr. Ashutosh.
I think first we should clarify with Dr. Abhijit. He, he may be having some slide on each topic. So after the presentation, we can discuss the thing. Dr. Abhijit, are you there?
Yes, I'm here. See, I've got the slides on my computer, and now how do I share them? Do I open them first?
Sir, you can.
Nupur, please make sir as a presenter so that he can share the slides.
Sir, you can go to share screen.
Share.
Down, share screen. Yes, yes. And there,
Uh, no,
once you,
please tell me, should I open the slides first?
yes, sir. You have to open the slide first.
Okay, I've opened the slides.
Then you have to go on share screen.
Okay.
Then go to Windows, sir, and select the slide which you want to share.
Okay. Zoom
And then
meeting.
you can just share.
Okay, I'll do that.
Yeah, yeah.
Good morning, sir.
Good morning, Dr. Pallavi. How's life?
Good, sir. How are you, sir?
I'm fine. Shubh Dashera.
Happy
Great. Yeah,
Dasara, sir.
I'm trying to get things right. Yeah, I have opened it. And now, Zoom.
Sir, go to share screen. You will have option down, na share screen.
Okay, share. Yeah,
Yeah. So in that, once you launch, it will show three options: Chrome tab, Windows, and
can
entire.
you see it now?
Yeah, yeah,
Can
we are able to see, sir.
you're able to see it now?
Yes, yes,
Okay. Shall I start?
yes, sir. Please.
Yes, sir.
So, Dr. Ashutosh and Dr. Pallavi, it is my suggestion that I will I will show you the slide for each of the topics, and then I think the other participants can chip in. Is that okay with you? Can you hear me?
Yes,
Hello?
sir. Yes, sir.
Yeah.
Yes, sir.
So,
Yes, sir.
so the first topic is Fenderon efficacy in heart failure across LVEF categories. Background. All the previous studies were done with steroidal mineralocorticoid receptor antagonists like spironolactone. They reduce morbidity and mortality in patients of heart failure with reduced ejection fraction, but their efficacy in those with heart failure with mid-range ejection fraction or preserved ejection fraction has not been established. The Fine Arts Heart Failure Trial was published in New England Journal of Medicine, September 1, 2024. It was an international double-blind randomized controlled trial. The patients had heart failure, ejection greater than equal to 40%. They were arranged in a 1:1 ratio with half the patients receiving Finrenone 20 or 40 milligram once daily versus matching placebo in addition to the usual heart failure therapy. The primary outcome was a composite of worsening heart failure and death from cardiovascular causes. Now, what were the results? There was improvement in the Kansas cardiomyopathy score as reported by the patient, but no improvement in the New York Heart Association functional class. The, uh, the scientists concluded that there was a significant lower rate of a composite of total worsening heart failure events and deaths from cardiovascular causes than placebo. The limitations were number one, there were very few Black patients. Number two, the trial was conducted during the COVID-19 epidemic. And number three, uh, was it or was it not a class effect? So, Dr. Ashutosh and Dr. Pallavi, I think you can start the discussion.
Yes, sir. It is very good to see another molecule in this area, like the phenomenal. And yeah, as you have rightly pointed out, that this is the molecule which has shown promise in the area of heart failure across the left ventricular ejection fraction. And if you see, probably this molecule is one which is showing the beneficial effect across the spectrum of the left ventricular ejection fraction, be it the less than 50% or mid-range or heart failure with preserved ejection fraction. Apart from this, Quinolone has consistent effect on worsening heart failure also. So this molecule is turning up into a very good molecule, and uh, the it can be utilized well in the heart failure with preserved ejection fraction. So what we can infer from this is it can be a very helpful molecule in terms of risk reduction. It is a very important molecule in terms of event rate reduction, as it can reduce the event rate across the all spectrum. And if you combine with the other molecule like SGLT2 inhibitor, which has also shown the beneficial effect across of the left ventricular ejection fraction. This can be a very good molecule in terms of treatment of heart failure. Apart from this, The molecule is also very good in terms of the safety profile, as the hypercalcemia can be managed, and it is a very good molecule if your patient is having worsening renal function. So, if your patient is having worsening and hyperkalemia, these two molecules, like the SGLT2 inhibitor and quinolone, again becomes very, very important. So, what I see that across the spectrum of the left ventricular ejection fraction, this molecule has got very good role in terms of cardiovascular protection. And we all know that approximately 15% of the patient of diabetes are having this molecule as an anti-inflammatory molecule and acting differently from the SGLT2 inhibitor. This can be a very good molecule
Hello, hello, hello.
Dr.
Uh,
Ashutosh, you
uh,
are breaking.
Sometimes the internet connection is becoming unstable. So
Yeah,
I
yeah.
Yes. Hello, Dr. Ashutosh. You are not audible.
now, if he is not audible, till such time that he becomes audible, I'll take over. Then when I can hear him, I give it back to him. Is that okay with all of you? Hello, hello.
I am not audible. Hello.
Now I can hear you.
Okay, okay.
Yeah, yeah. Please
So,
go on.
where I was.
You were saying that it is an excellent molecule because the hyperkalemia is not much and not dangerous, and it
Yes.
can the molecule can act across a wide spectrum of heart failure, like reduced ejection fraction, then mid-range ejection fraction, and then preserved ejection fraction. That is where we missed you. We
Yeah,
got
yeah. What I was saying, that since this molecule has got different mechanism of action, and it is also acting across the all spectrum of the ejection fraction, this can be a very good companion of the SGLT2 inhibitor. And now, along with the SGLT2 inhibitor, if you are using this molecule, particularly if your patient is having renal problem, this can be a very good drug uh, in the treatment of heart failure uh, across the spectrum of the ejection fraction.
So we are utilizing this drug in.
yeah.
So, actually, this drug is utilized in those cases where CKD is present along with the heart failure. So,
Yeah.
this is very good molecule in these subgroup of
No,
patients.
this is an excellent one.
Anyone wants to add anything which is left, so that we can incorporate the information into the newsletter? Anyone?
Dr. Ashutosh,
Yeah.
if nobody else has anything to say, may I say a few?
Sir, I
Yeah,
have one question. So,
yeah,
is it like wherever we were using aldosterone or lesilecton, can we use in the same place phenylalanine? Is it that we are trying to give the message over here? That molecule we have
Doctor.
already been using in heart failure.
yeah.
Is
Doctor.
phenylalanine a better developed drug instead of lesilecton? That's what is my question.
Yeah. The thing is, look, the spironolactone is a old drug and it is effective. We know all the side effects and effect, and this drug is very, very important. Uh, the what the spironolactone has does, that it has got some better safety profile in terms of hyperkalemia, in terms of patient, its usability in the renal patient, and its anti-inflammatory effect, and some of the endocrinological abnormality. So since this is acting through different pathway, the at least this drug is as efficacious as the spironolactone, but the problem is the cost. So if the cost is the consideration and the adverse effect is not that much prominent, you are able to manage the adverse effect, then you should still use the spironolactone. Or if because of the side effect and because of other things, the use of spironolactone is limiting, in that case, you should always go for this molecule.
Yeah,
Thank
That
you,
is
sir.
my
Thank,
take.
I entirely agree with you, Dr. Ashutosh.
thank you.
Spironolactone has got a cyclopentano perhydrophenylphene nucleus similar to that of cholesterol, and it is similar to some of the sex hormones, and it gives rise to gynecomastia in a significant number of patients, painful gynecomastia. So the next molecule which came was eplerenone. But may I draw your attention to a certain top cat trial which was carried out about 10 years ago, that it included patients with heart failure and reduced ejection fraction, as well as mid-range ejection fraction, as well as preserved ejection fraction. Now, the results in the case of preserved ejection fraction and mid-range ejection fraction just missed the mark. It was
Yeah,
not statistically significant.
yeah,
Later,
yeah,
on subgroup analysis, it was discovered that one of the participating centers, namely Georgia, which was one of the erstwhile USSR republics, they also participated, but their clinical and laboratory methods were not up to the mark, and so their data was deleted. And ultimately, they found that all the data from America showed that it was significant, but when you add this Georgia data, then it becomes insignificant. So
yeah,
a trial of this type with mineralocorticoid receptor antagonist was long overdue, and it has been proved that the mineralocorticoid receptor antagonists are effective in reduced ejection fraction, mid-range ejection fraction, as well as preserved ejection fraction. The last line of this slide is number 2, query class effect. Probably it is a class effect, but as of now, we cannot say.
yeah.
Sir,
I took
one more
so
question I had, that this spironolactone finds its use also in the treatment of hirsutism also. So is finerenone going to later on be used for the same purpose?
no, no. No,
No.
since the pathway is different, so
Yeah,
this
yeah.
molecule cannot be used in hirsutism and other endocrinological abnormalities since it has minimal effect on the endocrine system. So
Okay.
it
Thank
is
you.
not.
Yeah, I
It
got.
is not, and I
That.
totally agree with Dr. Abhijeet regarding the effect of the Top Cat trial, and it is very important to analyze the data in terms of the data with Georgia or without Georgia. It is very, very important. Another point is BP reduction. The BP reduction is more with spironolactone as compared to the phenomenon. So this is something which we should also incorporate. And if you look at the ventricular remodeling effect, the both molecules are having a similar effect. So this becomes a very, very important because many times we use spironolactone, phenolone as anti-ventricular remodeling molecule uh, in various circumstances. So uh, the both molecule are very, very important. We should choose judiciously, particularly in terms of financial thing, to treat the patient. So we should move on to the next topic, and that next topic is semaglutide benefit in heart failure without diabetes. Okay,
You see, Dr.
over to sir.
Ashutosh, yeah, it has become slightly jumbled up. I thought it would be better to discuss the CV risk in patients without diabetes mellitus, and then I'll talk about the heart failure later on. So
Okay,
this
okay,
is
okay.
the benefits for CV risk reduction in patients without diabetes mellitus. Now, semaglutide and CV outcomes in obesity without diabetes. It was published in the New England Journal of Medicine in 2023. This was known as a SELECT trial. Now, what was the background? Semaglutide, a GLP-1 agonist, has been shown to reduce the risk of CV events in patients with diabetes mellitus. Now, whether it can reduce CV risk associated with overweight and obesity in the absence of diabetes mellitus was unknown at that time. Now, the investigators carried on a multi-center, double-blind, placebo-controlled randomized trial. The age of the participants was more than 45 years. They had pre-existing cardiovascular disease. The BMI was more than 27, but they had no history of diabetes mellitus. They were randomly assigned to receive in a 1:1 ratio weekly subcutaneous semaglutide at the rate of 2.4 milligram subcutaneous or placebo. The primary CV endpoint was a composite of death from CV causes non-fatal myocardial infarction or non-fatal stroke in a time to first event analysis. The safety was also assessed. Now, what was the conclusion? They concluded that semaglutide was superior to placebo in reducing the primary endpoint at a mean follow-up of about 40 months. The p-value was highly significant. The limitations of the trial were: one, the trial included patients with documented cardiovascular disease. The effect of semaglutide in the primary prevention of cardiovascular disease in overweight or obese patients was not assessed. So they were talking about secondary prevention, but they did not address primary prevention. And number two, only 27.7% of the patients were women, which is an underrepresentation, as well as 3% were blacks, that is also underrepresentation. Now, please go on with your discussion.
Yeah, rightly said, sir. As this molecule is gaining much more importance in our clinical practice, and there is significant risk reduction of the semaglutide to reduce the risk of major cardiovascular effect, particularly the if you talk about the composite primary endpoint of cardiovascular death, non-fatal myocardial infarction, stroke. So there is consistent benefit, uh, particularly in case of obese patient. If there is mean weight loss, which is persistent a period of 104 weeks, so this is very important. Apart from this, the important thing about the blood pressure reduction and anti-inflammatory effect of this molecule, which has shown that there is a reduction in C-reactive protein. Its effect in diabetes prevention and kidney benefit is well known. And the long-term follow-up data up to 34 months to 40 months is available. So what we can see that here the mean follow-up was 39.8 months. So that becomes very, very important, because a molecule which is super and follow-up data up to 40 months is available, that becomes a very, very important. And in this scenario, this molecule is very much beneficial if you are using in obese patient having high hsCRP, having renal problem, elevated blood pressure, and they are having multiple component of metabolic syndrome. Over to you, sir.
Dr. Ashutosh, I think I involve the other participants. Let them say what they want.
Next.
Dr.
The
Ashutosh,
CHF one.
yeah, anybody, please join. It will make the discussion more lively. Any questions, please?
Sir,
Sir, what about?
Yes, please go ahead.
actually, I wanted to know whether the oral semaglutide will hold the same kind of benefit which was observed with the subcutaneous semaglutide.
I'm afraid I'm a cardiologist. I can't say much about that. Maybe Dr. Ashutosh or some of our endocrinology colleagues can join in and share their opinion.
Right now, the data which is available with us is of subcutaneous semaglutide. The oral semaglutide data are still coming. Once we analyze the data of long-term data of the pioneer uh, studies, then only we can answer this question. And after the SOL data and other data on the weight loss study of the oral semaglutide, we will be more wiser to answer this question. But one thing is very sure that since the mechanism of action of the two molecule is almost similar, they are likely to have similarity.
Thank you, sir. Thank you.
Thank you. This is a question to the other participants, the other faculty members. I have been observing over a period of months that there are a lot of people in India and maybe abroad who are taking semaglutide for weight reduction in the absence of kidney disease, in the absence of cardiovascular disease. How far justified do you think that this action is? This is off-label use of the drug.
Oral semaglutide.
Even
Oral
subcutaneous.
semaglutide, what they are using as a weight loss drug
Yeah.
in the dose of 50 milligrams. So
Yeah.
there are trials which have shown that if the oral semaglutide which has been taken with the 50 milligram per day dosing, it is very consistent in terms of weight reduction, and it can reduce weight up to more than 20%. So semaglutide is very good drug also in terms of weight loss, and there are data regarding this. And if it is used in higher dose like 50 milligram, it can be effective.
Dr. Ashutosh, this is like the Chinese debt trap in which there are many countries in the Indian Ocean region, they are falling prey. Like, if somebody wants to reduce weight and they start taking semaglutide, they'll have to continue it for life. And the moment they stop, the weight starts going up again.
Yeah.
And just look at the cost. They will sell their property to buy semaglutide.
Sir, yes, this is also a concern, sir. But the thing is, we should innovate on all these things and design our way of using the oral semaglutide without
Certainly, Dr. Ashutosh, maybe you're talking of biosimilars that are being formulated by India pharma companies. Am I
Yes.
talking right?
Sir,
Yes,
at this
sir. Yes.
point, sir, at this point, I wanted to share a concern. Like
Yeah.
I am in a general practice. One of my patient was using Elevate kind of app for weight reduction. It was for exercise, lifestyle modification. Then she had a consultation with a doctor in the app, and he told her to take semaglutide. So she came to me and she wanted to get it issued. That's very matlab scary. Like if such platforms are advising the people, like I know because I'm in a government setup, she wanted to me to issue the medicine, but she could always buy it also. So is there any restriction over the counter medicine for buying semaglutide, or is it easily available? It's only depending on the affordability of the person, I think. He can buy and
Yeah.
use it, I think.
Anyone in India can buy any medicine. The regulation here are not that much strict. That is the
Okay.
problem.
Dr.
Yes.
Saab,
But as of
yeah.
yeah. Go ahead, sir.
I am extremely scared about prescribing, off-label medicines. If some
Yeah.
patients gets into some trouble, then they will catch me by the neck.
Yeah, that's true, very true.
Yeah, I'm scared of all these fancy medicines which have no approval by regulatory bodies. So I will take my hands off on this controversy.
But sir,
Yes.
one thing is very sure that on basis of this oral semaglutide data of 50 milligram, that is Oasis trial, uh, uh, the very soon this oral semaglutide is going to be approved for a weight loss drug. Because if you look at the amount of weight loss
Yeah.
up to a tune of 20%. So, and if you look at the placebo versus the semaglutide, the difference is huge. So very soon you will get approval for the oral semaglutide being used as a weight loss drug. And 50 milligram dose may be the dose, and maybe in future company will come up with the 50 milligram dosing with the lower cost. That may be one thing. Another important observation which I have seen in my clinical practice is the drug holiday. If you create drug holiday or intermittent dosing, you can still have similar effect and you can maintain weight loss with lower cost. So that is one thing. So what I just want to give a message is actually uh, you can use the drug for the weight loss, and you can innovate the lower dose for weight maintenance so that rebound weight loss can be prevented.
Okay, we will look forward to its approval by the regulatory body. Can I go to
Yeah.
the next slide, please?
Yes, sir. Yes, sir.
Actually, this was scheduled to be the previous slide. I have purposely changed the order. You will understand why I have done it. First, I have done about secondary prevention, and then I have talked about heart failure. Now, semaglutide and cardiovascular outcomes in patients with obesity and prevalent heart failure. Now forget about this general cardiovascular disease. We are entering the field of heart failure, a pre-specified analysis of the SELECT trial. The previous trial was SELECT trial, and they have done subgroup analysis. It was published in August 2024, barely 2 months ago. And the investigators concluded that treatment with semaglutide resulted in improved outcomes in both heart failure with reduced ejection fraction and heart failure with preserved ejection fraction, although the patients of heart failure with reduced ejection fraction had higher event rates than those of heart failure with preserved ejection fraction. Serious adverse effects were less frequent with semaglutide versus placebo, regardless of the heart failure subtype. Now the discussion, please. Dr.
Regarding regarding the semaglutide and the heart failure with preserved ejection fraction, from this trial, it is clear that though the drug is very good in terms of weight loss, but if you look at the hard pointers of the benefit, the probably drug is not that much effective in terms of mortality, but in terms of uh, the symptoms in that is this constituting symptom scoring system. This drug is uh, a good drug in terms of improving the 6-minute walk test and other parameters. So in terms of symptom improvement, yes, you can use semaglutide even in heart failure with preserved ejection fraction. But in terms of the benefit, it is hard pointer benefit, it is not there. Regarding heart failure with reduced ejection fraction, if you are using this drug in combination of SGLT2 inhibitor, probably the combination of SGLT2 inhibitor and the GLP-1 is a better agent as compared to SGLT2 alone. So if you look at the comparison, the probably the combination of SGLT2 inhibitor and GLP-1 is doing better than the GLP-1 alone.
Okay, Pallavi, you want to join us?
Yeah.
Anybody else, please? Please join the discussion. Make it look more lively. See, Dr. Ashutosh, since not many people are joining this discussion, let me say a few things from my part. Until about 2 years ago, treatment of heart failure with preserved ejection fraction was absolutely hopeless for the cardiologist. There was no treatment which was of proven efficacy. And now the scene is becoming better. We are having a sunrise. First of all, it has been proved that SGLT2 inhibitors are definitely useful in the preserved ejection fraction group. Secondly, the mineralocorticoid receptor agonist, like phenidone. And third, the GLP-1 agonist. So there is hope for these people as well. And here it is important that many of these people, they are suffering from kidney disease, others from obesity, others from atrial fibrillation, maybe some level of hypertrophic cardiomyopathy, and once they start developing heart failure with preserved ejection fraction, it is a downward spiral, and death is the destination. But now we are having good things. So good luck for these people.
Another important thing, sir, just to add into the discussion, is there any role of Renola gene in patient with heart failure preserved ejection fraction?
Well, I am interested, but I have not come across any literature. Do you have any references?
No, sir. Just I was reading some of the article where it, though old one,
Okay.
that had shown some promising results. But in recent article, I don't find any mention about this molecule. That's why I'm just asking out
You
of
know,
curiosity.
when I find Dr. Ashutosh mentioning something, I know that he has read it somewhere. It can't be out of the blue. So maybe we are going to see more of ranolazine in the months or years to come. But right now, I don't have any reference.
Okay, sir. Okay, sir. So we'll try to include this in next discussion. So we should move on to the next topic.
So this is a research molecule. Uh, we are talking about uh, autosomal dominant polycystic kidney disease. The treatment has been very disappointing for many, many years. It is a disease characterized by bilateral kidney cysts that grow throughout life and lead to increase in total kidney volume. And increase in the kidney volume leads to progressive deterioration of renal function. The patients have flank pain, kidney stones, cyst infections, and hypertension. The mean age of CKD is between the fifth and seventh decades. These people also have hepatic, pancreatic, and splenic cysts, intracranial or arterial aneurysms, mitral valve prolapse syndrome, and aortic regurgitation. Two genes are commonly implicated. The first is the polycystic kidney disease 1 gene located on chromosome number 16, which occurs in about 70% of the people, and polycystic kidney disease 2 gene, which occurs on chromosome 4. This is about 30%. These are round figures. There are other, I mean, small contributions by other genes, which I have not discussed here. Now, this coded molecule RGLS8429 is a next generation oligonucleotide designated for the treatment of autosomal dominant polycystic kidney disease. It inhibits microRNA 17 and preferentially targets the kidney. It prevents the cysts from growing and causing progressive renal dysfunction. Preclinical studies have shown improvement in kidney size, function, and other measures of disease severity. So this is for discussion, please.
So before the advent of this molecule, the only known treatment which we can offer to our ADPKD patient is beta-lactam. Since these are these kind of patient who are losing salt-losing nephropathy, we don't have anything to offer. But with this oligonucleotide designed to treat ADPKD, this preferentially target the kidney and improve the function. And this is the molecule uh, which has got future in terms of treatment. As we all know, the ADPKD is not simple disease only in terms of renal involvement. It can cause hepatocellular carcinoma, pancreatitis. So this is very, very important to target this disease, as uh, only dietary modification and lifestyle modification was only available treatment before. But now this new exciting area is developing up, and we should uh, follow this, as the ADPKD is one of the common renal associated abnormality which we see in our cardio diabetes renal practice. And it can actually, if you are dealing with a cardiac patient with ADPKD, or if you are dealing with a diabetic patient with ADPKD, it can contribute in the renal progression, and ultimately it may cause CKD, particularly in a patient of 50 years to 70 years. So as diabetes and cardiac disease is very common in this subgroup of patient, so these are the these are the commonly associated disease which we can find in our clinical practice. And uh, this can be prevented also. So this is one of the important uh, development. That's why we thought that we should include this in our discussion.
Yes, Dr. Ashutosh, I entirely agree with you. And as far as I am concerned, I see a great future for this molecule. You know why? Because probably in the years to come, we will start administration of this molecule earlier in life, because the cysts continue to grow and expand as a person gets older, and the renal function deteriorates during the fifth to seventh decade of life. So suppose we start administering it early, then the patient will not have to undergo the ordeals of having this, flank pain, kidney stone, cyst infections, hypertension, and so on. So let's keep our fingers crossed. I think we are having great days for the patients of polycystic kidney disease. Anybody else? Would anybody join? Yes? Any participants, please? Make the discussion more lively.
Dr. Jagnani. Hello.
Sir, I have
Yeah.
one question.
Yeah.
Sir, how many times, do you come across such patients with autosomal dominant polycystic kidney disease? Have you, I just wanted to know on an average in
No,
an
I
OPD.
have come across these patients. I'll tell you the secret. I am a super specialist cardiologist. If you
Yes,
talk to
sir.
a super specialist nephrologist, then they will see many of these patients. For example, if you ask me how many patients of single ventricle or transposition or tetralogy of Fallot I have seen many, many. But maybe there are doctors belonging to other specialties maybe who have seen one or may not have seen many. So it all depends on the specialty that you are following.
Yes, sir. Yes.
Nephrologists
That's
will
true.
obviously see more, and probably at least one patient every day.
Okay.
Can I
And
go? Yes,
sir,
please.
how do you raise the index of suspicion? Because many times we see in the ultrasound there are cyst in the kidney. So how do you think that we can just not think in terms of polycystic kidney disease unless
No,
there's cyst in the liver
any
also?
any patient any patient which is coming in between the fifth to seventh decade of life, or a patient much younger, if having features of CKD without hypertension, without diabetes, without any autoimmune cause, or without any other obvious abnormality in ultrasound, if you look at the this type of finding, you can always suspect that ADPKD is one of the important finding, important cause. And
Oh,
specifically this subgroup of patient, they most of the time they don't have hypertension in the initial part, and gradually they develop um, uh, uh, the
mm,
hypertension. Initially, they present with the abdominal pain and the kidney stone, and
mm.
eventually, due course of time, we diagnose them with the polycystic ADPKD.
Okay, sir. Thank you, sir. Thank you so much for
Yeah,
making this.
I have something to add to this. If you get a good radiologist who does ultrasound these days, these people are very intelligent. They will tell you whether there is one cyst or there are many cysts, and they have got a Bosnian classification, whether this is a benign cyst or whether this is a malignant cyst, or whether this is multiple cysts all over both kidneys. In that case, they talk about polycystic kidney disease. And when they are seriously thinking about polycystic kidney disease, they will use the probe in a slightly different angle, and then they will scan the pancreas and they will scan the spleen and so on, and try to find out whether there are cysts in the other organs as well, which just vindicates their stand. Am I clear to you? But
Yes,
of
sir.
course,
Yeah.
but of course,
Yes, sir. Thank you, sir.
then after
Thank you,
that,
sir.
you will have to do a CT scan or maybe MR angio of the brain
Ah,
to find out about the intracranial aneurysm, and maybe a
he.
genetic study to find out the polycystic kidney disease gene. See, this is a complete workup that the nephrologist will do.
Yeah, definitely, sir. Thank you.
Thank you. The next one. This is desidustat for treating anemia in chronic kidney disease patients. Desidustat, this is known as oxemia, this is a trademark, is an orally available small molecule hypoxia inducible factor prolyl hydroxylase HIF-PH inhibitor, which results in stabilization of hypoxia inducible factor, which stimulates erythropoietin production and erythropoietin. It was developed by Zydus Cadila for the treatment of anemia associated with chronic kidney disease, COVID-19 infections, and chemotherapy-induced anemia. It was approved in India in March 2022 for the treatment of anemia in adults with chronic kidney disease with or without dialysis. It is non-inferior to darbepoetin alpha in the treatment of anemia due to non-dialysis dependent CKD and is well tolerated. The DREAM ND trial phase 3 study, American Journal of Nephrology 2022. Now, this is for discussion, please.
This is very
Anybody?
important molecule in terms of the future treatment of CKD patient, as we all know that erythropoietin stimulating agent we classically use for the treating anemia in CKD patient. But the problem with all these erythropoietin stimulating agents are they can increase blood pressure, they can increase risk of atherothrombosis. And we all know the common cause of mortality in CKD patient is accelerated hypertension and the erythrothrombosis. Sometime in our CKD patient, the accelerated hypertension and uncontrolled hypertension becomes one of the important limitation to use the erythropoietin stimulating agent. The beauty about this molecule, that is uh, the decidustat, that is hypoxia inducible factor, is that this molecule has got some uh, uh, anti-inflammatory property also, and this is one of the molecule which is thought to be one of the important agent in terms of reducing the cardiovascular mortality if you are using in the CKD patient. So in future, we will know about more about this molecule, and it is going to be one of the important agent uh, uh, in terms of treating CKD patient who are at risk of cardiovascular disease. The important limitation of this molecule is the nausea, vomiting, pyrexia, and increased risk of hyperkalemia. So this is very important to note that any patient who is having all these side effects, they should be monitored, and they should be uh, 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 use this agent very cautiously, and to improve the utilization of this molecule, one needs to know what are the subgroup of the patient where this agent is most effective. Like we all know that in CKD patient, the ferritin levels are high, and to get the exact status of the iron in CKD patient, probably iron TIBC is better agent test as compared to the ferritin. And since ferritin is the inflammatory marker also, so what they are advocating is if your CKD patient has decreased hepcidin level, they are a better subgroup of patient where this desidustat can be used, and they will improve the iron utilization, and iron overload can also be prevented by by adopting this type of approach. So in future we will listen more and more about this molecule, and they have opened a new way of treating anemia in case of CKD patients.
Thank you, Dr. Ashutosh. As you have rightly said, that the more erythropoietin that you give, the more the risk of hypertension, the high level of blood pressure sometimes becomes difficult to manage. There is also there are also reports of venous thrombosis and embolism, and also it is like an instinct for most doctors to try and improve the hemoglobin level to a normal level of about 13 or 14, but then the optimum has been found to be about 10 grams per deciliter when it comes to treatment with erythropoietin or darbepoetin alpha. Because if you increase the hemoglobin to a level higher than this, the chances of complications will be more. It has to be seen in the months and years to come whether this desidustat, that is oxemia, can permit higher uh, hemoglobin levels. This is important for me as a cardiologist because for my heart failure patients who also have chronic kidney disease, I would like to have higher hemoglobin levels because that will carry more oxygen and put less stress and strain on the heart. Any other participants, please? Anybody like to join? Now,
Yes,
cardiovascular outcomes in, yes, anybody please?
yes, sir. Is this molecule available in India, and what is the dose? How do you administer it?
You know, if see the second point, it was approved in India in March 2022 for the treatment of anemia in adults with chronic kidney disease who were not on dialysis. Uh, I am not a nephrologist. I can tell you the brand name. It is Oxemia. It is marketed by Zydus Cadila. You can find the price from the internet.
Yes, sir. Thank you, sir.
Anybody else? Okay. The next slide.
Yeah. Yes.
Anybody
Go
else,
ahead.
please? Please join.
No, no, go ahead. The doses, Dr. Pallavi is going to tell.
Okay, Dr. Pallavi.
So doses are 100 to 200 milligram. But actually, we don't have this drug in our clinic or in our periphery. So we are not utilizing this drug. But this is definitely a future drug which we can utilize.
Promising.
Dr. Pallavi, I think the, the cost should be prohibitive.
Pardon, sir? Hello?
Cost.
I think it must be very, very costly for the patient. What is the price?
Sir, we don't have, so we don't know the cost of this drug.
Okay.
But we are actually waiting for this drug.
So even we are not using, I'm in Delhi, but I get prescription from all the bigger hospitals and we are issuing medicine. Till now, I have not got any prescription of desidustat. And Rababoitin, definitely there are a lot of prescriptions, but not for
Gazapoitin
desidustat.
has been there for over 10 years.
Yeah, but
You
not for
know,
desidustat.
this is what the manager of an important pharmaceutical company told me many years ago. He said that, doctor, we spend a lot of money for the development of new drugs. If we spend money on 10 or 15 new drugs, maybe one comes to the market and all the rest get rejected. So it is a huge expenditure. And if we spend so much of money, the company will like to recover the money. Otherwise, they are not going to make any fresh expenditure on new molecule. Then he asked me a question. He said, Doctor, suppose you have written a textbook and the textbook is available in the market for 10,000 rupees. And suppose somebody makes a Xerox copy of that book and sells it for 400 rupees. How would you like it? I kept quiet and I had no answer to what he said. So the next slide, cardiovascular outcomes in patients with chronic kidney disease. CKD patients, they have higher rates of silent ischemia and higher rates of serious arrhythmias, mainly ventricular. There's a diagnostic confusion because in about half the number of stable patients with chronic kidney disease, the HS cardiac troponin I or troponin T are more than the 99th percentile of normal. The degree of elevation is related to LV mass, coronary artery disease, severity of renal disease, and all-cause mortality. Thus, cardiac troponin I is more useful in patients with acute chest discomfort, while chronic elevations are more common and more prognostic in stable ischemic heart disease. Chronic elevations of troponin T, sorry for the mistake. The diagnosis of acute coronary syndrome is done by serial estimate of troponin I, showing 5 times rise above the first value. To continue, renal dysfunction and prognosis. The CKD patients represent 30% of STEMI and 42.9% of non-STEMI patients. There is higher in-hospital mortality, which is directly proportional to the extent of renal dysfunction. There is higher 30-day and 1-year mortality after ACS. There is reduced baseline EGFR, which predicts higher rates of acute kidney injury, bleeding, development of heart failure, recurrent myocardial infarction, rehospitalization, and stroke in the setting of acute coronary syndrome. Patients of end-stage renal disease have the highest mortality after myocardial infarction. Now, what are the reasons? First, excess comorbidity, such as diabetes mellitus and LV dysfunction. Secondly, therapeutic nihilism. Thirdly, toxicity of therapies. And fourthly, special biological and pathophysiological factors, cytokine elevation, excess thrombin generation, decreased platelet aggregation, pro-inflammatory oxidative stress state. Now, for the discussion, please. Dr. Ashutosh, Dr. Pallavi, as well as the other faculty members, please. Please join.
Sir?
Yeah. The cardiovascular problem in CKD is very widespread. We all know that these patients are at risk of cardiovascular coronary artery disease. They are at risk of heart failure also. And arrhythmia and sudden cardiac death is very, very common. And to add to the complication, if the patient is on dialysis, or if the patient is receiving multiple agents uh, which can cause calcium deposition inside the arteries, like the phosphate binders, these can aggravate further problem. And it is very important to protect all these patients. The problem in these patients are we will lose eventually the AC inhibitor or ARB because of the fear of hyperglycemia, and inappropriate fear, I should say, because these agents can well be used. And according to the renal trial and the other trial, the losartan and the ARBs are the actually drug of choice, but we tend to be a little bit defensive in terms of using this molecule as an antihypertensive molecule in our CKD patient. That will increase the chances of cardiovascular mortality as well as rate of progression of cardiac disease. The complexity is so much so that if the EGFR declines from the 60 to the 15, the chances of cardiovascular mortality goes up to 4 to 5-fold. So that is very important. And proteinuria being one of the independent risk factor for the cardiovascular disease and the kidney problem, it becomes a very important part. And since sympathetic outflow in CKD patients are very high, the uh, important hormonal imbalances will lead to increased sympathetic outflow, and this sympathetic outflow will cause left ventricular hypertrophy and kidney failure. And anemia, other risk factor, like we all know that the CKD is the inflammatory condition, the calcium hyperphosphatemia, the uremic toxin, as well as uric acid increase. They not only increase the progression of CKD, but they also contributes actively in the renal, the cardiac abnormality. So these are few things which I just want to add. And over to Dr. Pallavi for some of the other points. Anything you like to add?
So definitely, sir, we are actually having these type of patient because we are running the integrative clinic. We have diabetologist, cardiologist, and nephrologist. So most of our patients are having CKD with cardiovascular disease, with diabetes, and we are actually working on preventive part of renal progression and cardiovascular risk assessment, and to choose a better drug for diabetes treatment, so that that drug also prevent renal progression as well as ca- cardiovascular risk prevention. And the anemia is very important, one of the very important factor which is present in this subgroup of patients. So we have just discussed about one very important drug, a future drug which will help in the treatment of anemia, that desidustat. And also we are more interested in prevention of stroke, peripheral vascular disease in this subgroup of patient, and treatment of hypertension in this CKD patient. So these are few factors which we are looking for.
Apart from this, the important change which has occurred in this time is the combination of use of the ARB, ARNI, and SGLT2 inhibitor, the GLP-1, and recently the first topic, that is the non-steroid mineralocorticoid receptor agonist along with the statin. So combination therapy of statin, ezetimibe, non-steroidal mineralocorticoid receptor agonist, glucagon receptor polypeptide, SGLT2 inhibitor, and RAS. This is very important in terms of mm, reducing the cardiovascular mortality in this patient. And with the advent of the trial like ischemia CKD, that has shown that the medical therapies are gaining much more important in uh, this area. And if somebody is using optimized medical therapy, there is a hope for uh, these patients, because all patients in this group are not going to go for the intervention, and particularly if the dye used in the invasive procedure are harmful to the kidney patient. This can be one of the way. Dr. Uh, Abhijit will guide us in a better manner regarding the implication of the ischemia and ischemia CKD trial.
Dr. Ashutosh, when I have a patient of stage 4 or 5 CKD, I always have a nephrologist on board and I write it down on, on the patient's history sheet that he should come and see the patient on a daily basis. You know why? Because we use a lot of medicines, as you mentioned, like ACE inhibitors, ARBs, mineralocorticoid receptor antagonists, and SGLT2 inhibitors, which may affect the glomerular filtration rate and the EGFR. And also heparin, low molecular weight heparin, then rivaroxaban, apixaban, abciximab, and tirofiban. It's always good to have a nephrologist on board. Otherwise, you will either be too timid and you will not prescribe the medicines for fear of causing harm, or else you will be too aggressive and cause harm. It is better
Yeah.
to have a colleague with whom you can share your ideas and then jointly write a prescription. I always
Yes. Yes.
can I
So
go?
That is
that
the practice in
that
our center also, sir.
Yes,
Our
absolutely
friends.
right. Yes, sir. Please go ahead. Hello.
Another point which I just want to emphasize is regarding the LDL cholesterol reduction targets in the CKD patient. Many people think that now the patient is having CKD, the statin will not work, and we should reduce the dose of the statin. But the main point is, in terms of LDL cholesterol reduction, we should have been more aggressive rather than being more defensive. So if your patient is having CKD, and high cardiovascular risk, then LDL cholesterol reduction targets are more aggressive, and you have to intensify the therapy, particularly in pre-dialysis patient. So these are the subgroup of patient where you should intensify the therapy, and if possible, use ezetimibe. We should not confuse with the KIDGO guideline, which says that the ezetimibe alone should not be used. The ezetimibe alone has not uh, shown any benefit, because there is no data with the ezetimibe alone. But we have data from the statin and ezetimibe combination, which clearly shows that there is substantial amount of benefit once you are adding the ezetimibe to the high dose or intermediate dose statin, and this will have benefit in terms of cardiovascular risk reduction as well as cardiovascular disease. All the guidelines from the various society has also recommended the use of high dose statin in CKD patients. So my simple request is to just review the literature according to the European Society Cardiology guideline and other guidelines also. We should use the high dose statin in this subgroup of patients. There is tendency among the physicians and doctors to reduce the dose of statin once the patient develops CKD in the fear of unwanted side effects. So, Dr. Abhijit, your opinion, please.
Dr. Ashutosh, I entirely agree with you. You know, I have come across doctors who have said that this patient is suffering from CKD5, and how long do you think he is going to live? And what do I gain by reducing the cholesterol? I can only increase the number of side effects. But this is not right. You know, this is not a wise decision, because the use of this statins is not for bringing down the cholesterol alone. Statins have a lot of pleiotropic effects, which cause beneficial effects on the vascular endothelium. So to stop statins is like committing suicide. You are absolutely right that they should be used in the full and proper dose recommended by the guideline. Can I go to the next slide, please?
Yes, sir. Yes, sir.
This is SGLT2 inhibitors for cardiorenal protection in diabetes mellitus. The upper part of the slide is for cardiac, and the lower part of the slide is for renal protection. So cardiac first, because I'm a cardiologist. Lower systolic and diastolic blood pressure by 3 to 4 millimeter mercury and 1 to 2 millimeter mercury respectively. Effect is greater during day and persists over a period of time. They reduce the risk of heart failure and CV death in patients with and without diabetes mellitus. The SGLT2 inhibitors reprogram the patient's metabolism to a fasting-like state, and this is responsible for cardioprotective effect. Regarding the renal effects, they reduce the risk of renal failure and death, and the composite of renal failure, kidney death, and doubling of serum creatinine. They protect the kidneys of patients who do not have diabetes mellitus. The mechanism of renal benefit is postulated to be the reduction of intraglomerular pressure, simultaneously lowering GFR, but thereby improving glomerular hyperfiltration and protecting the kidney. Now, your discussion, please. As many people as possible, please join. Dr. Ashutosh, Dr. Pallavi. Hello.
Hello.
Yes.
Yes, sir. So it is very, very important that we should discuss this SGLT2 in the area of cardio diabetes and renal disease, because this molecule is a statin, like a statin in recent area. So there are cardiovascular benefit because it can reduce major cardiovascular adverse effect by 11%. It can reduce hospitalization of heart failure by 23%, and it can improve the heart failure outcome by 30% reduction. So MACE 11%, the hospitalization of heart failure 30% reduction, and there is 23% reduction benefit seen in patient with ASCVD patient. Apart from this, the potential reduction in cardiovascular death is also seen. There is also a need for dialysis, and renal replacement is also reduced up to a tune of 30%. So there is a hardcore renal benefit is there, and there is decreased albuminuria and renoprotective effect. So the cardiorenal benefit is obvious with the SGLT2 inhibitor, and this is one of the important drug in treating this area. Regarding the mechanism of action, there are various mechanisms of action implicated, like sir has already pointed out. The effect is expanding mm, by every study. But important point is the anti-inflammatory, anti-oxidative state, anti-fibrotic effect, and mitochondrial dysfunction is one of the important target which has been recently added in this. So the molecule is very, very important in terms of cardio, renal, and in diabetes patient, and the effect is consistently shown across the trial. And the if you are able to manage the UTI with um, judicious use, like if you gradually increase the dose, you can try the fluconazole prophylaxis, educate your patient, and if you have treated the other condition, and if you have evaluated the risk of UTI in your patient, then you can give the benefit of this drug to many patients. Like what I was seeing in my chat box, that people are asking about how to manage the UTI in SGLT2. The using SGLT2 inhibitor is an art. And one very important point is, if your patient develop UTI with the SGLT2 inhibitor, withdraw the drug, treat the UTI, and after treatment of UTI, again reintroduce the drug. And if your patient is recurrently having UTI, then give fluconazole prophylaxis like day 1 to day 10 every month for 3 months. Then gradually, patient will tolerate the therapy, and you will find that once the patient who was very intolerant in the beginning is tolerating the same therapy easily, and in due course of time there is no side effect like UTI. Another point is, if your patient is having very high risk and increase RBS at the initial point, you can try intermittent dosing, and gradually you can go to the continuous dose to alleviate the symptoms and to reduce the risk of UTI. So this is very important. The person who are having urethral stricture, BPH, and the female patient postmenopausal, uh, they are particularly at the risk of developing UTI, but with adequate education and prophylaxis, you can manage the UTI very well in these patients.
So Dr. Ashutosh is right. Actually, we are utilizing this drug, and we have seen that initially patient develop UTI, and it was very difficult to continue this drug. But in future, the UTI was not there, and patient was tolerating in very stable manner. So UTI should not be a fear to use this drug. And this drug we are also utilize, and people are also utilizing this drug as a smart diuretic also. So whenever we want to give a benefit of weight loss along with diabetes control, sugar level control, and renal benefit, and in heart failure benefit, then we can utilize this drug, and we can increase this the dose of this drug. Like we can utilize it as a BD dose, like we are utilizing dapagliflozin in BD doses, so that this drug can give more diuresis and a smart diuresis.
Yeah, sir. This is one thing which we are recently seeing that we have done some research in this area also. What we are seeing, that maximum permissible dose for DAPA is around 30 milligram, which has been used in trial. So if you are encountering a difficult patient where you don't want to increase the dose of diuretic, you can actually try the dose, particularly if the patient is obese and they are not having much osmotic symptoms like polyuria, polydipsia. This subgroup of patient can be one of the, with of course normal renal function. So this subgroup of patient may be one where you can try at least this drug, or you can try the drug with both SGLT2 and SGLT1 inhibition. So this is important. Another point is the volume. Volume depletion and dehydration. So you have to choose the your patient judiciously. If your patient is dehydrated, you should always decrease the dose, and you can try intermittent dosing, and then you gradually increase it. The risk of diabetic ketoacidosis is always there, particularly in malnutrition patient who are elderly patient. They have a tendency to fall also. So frail, malnourished patient who have lower blood pressure and tendency to fall, this subgroup of patient, actually SGLT2 inhibitors should be used judiciously. So bone fracture risk is high in this subgroup of patients. And as you have already rightly pointed out, that risk of acute kidney injury may increase if you are using the drug along with other diuretics. So apart from this, one important thing which people may forget, that its potential drug interaction with the digoxin and lithium. So if you are using this molecule along with the digoxin and lithium, you should monitor the dose of these two drugs, lithium and digoxin, uh, 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 and watch for their side effects. So selecting appropriate patient is very, very important if you are using um, the SGLT2 inhibitor. And as a protocol, if your patient develop any temporary illness, like we all know that SADMAN is the mnemonic for the drug which has to be stopped for the um, patient who are having acute illness. The SGLT2 inhibitor along with NSAID, metformin is the drugs which should be stopped, and temporary discontinuation is required. And once your patient improve, you will reintroduce this drug. So it is true that SGLT2 inhibitor has got various um, benefit, but it is also important to use this molecule judiciously.
Dr. Ashutosh, hello, can you hear me?
Yes, sir.
You know, we have been discussing for nearly an hour and a half, and
Yes, sir.
this is a Sunday, and
Yes,
we are all family people, and
yes, yes.
maybe the lunch is getting cold in our homes. So shall I call it a day, and we can have a discussion sometime next month?
Yes, sir. Yes, sir. Yes, sir. We should continue this the topic number 8 to 12. Pratima,
Yeah.
please note down that topic number 8 to 10 should be
12.
8 to 12 should be taken for the next month discussion, and
Yeah.
circulate this, and we will make a newsletter from topic number 1 to 7. Thank you so much, sir. Thanks for your input.
Thank you very much.
Thank you, everyone. Thank
Thank
you,
you,
sir.
sir. Thank you very much,
Thank
Thanks,
you
sir.
so much.
thanks to the organizers, all the
Thank you, Dr.
participants,
Abhijit, Dr. Yasmin, Dr.
and
Thank you,
Nikhil,
ma'am.
Dr. DK Jagnani.
and
Thank you
also
so much.
also
Thank
Mrs.
you.
Pratima Singh and members of the staff for making everything worthwhile. Bye.
Bye. Thank you. Have a happy Sunday, sir. Bye.
Same to you.
Happy Sunday, everyone.